Today we're going to talk about inguinal hernias. Hernia is a protrusion of viscus or a part of viscus from the cavity it contains. So there are various types of hernias, and inguinal hernia is one of the common abdominal hernias. And these are few other hernias according to the types. And this is a diagrammatic representation of the superficial inguinal ring, and you can see the fascia transversalis and the muscles. So inguinal canal is 4 to 6 centimeters long, and it starts from the abdomen from the point where the spermatic cord crosses the internal or deep inguinal ring and traverses and the transversalis fascia. And women it is called as there's the round ligament, and this canal finally ends in the external surface of the inguinal ring at the level of the abdominal muscles, where the spermatic cord passes from the aponeurosis of the external oblique muscle. And it's about 75% of all the hernia that happens in the inguinal region. 90% of them are men and 10% are women. 70% of the femoral hernias repairs occur in women, and although the prevalence of the inguinal hernia is common 5 times that of the femoral hernia, and the most common inguinal hernias in women and men is indirect inguinal hernia, and the prevalence of the hernia in men has two peaks ages under 1 and above 40. The laparoscopic hernia repair of the hernia and the diagnosis of the contralateral hernia can be made, and the femoral hernia in the elderly and those with who had previous hernia repair is most common. The prevalence of the inguinal hernia increases with the age, especially in men. Inguinal hernia in adults is mainly from the acquired weakness in the abdominal wall, and the most important one is the defect of the abdominal. So the etiology, it could be acquired or congenital. The congenital hernia consists of the most cases of the pediatric hernias. Acquired hernia, it causes come from the acquired defect in the abdominal wall, and the reason for this is formation is multifactorial: exercise, positive family history, COPD, collagen deficiency, and associated with aneurysms. Symptoms are variable from the hernias, no symptom to strangulation. Asymptomatic hernia is either found on the physical exam or the patient himself realizes there is a bulging found during, or it can be found during laparoscopy. Symptomatic patients mostly present with the inguinal pain. Sometimes the patient present with the symptoms outside the inguinal region, such as change in bowel habit or urinary symptoms. Pressure in the nearby nerves, or there is feeling of pressure in the daily activity, sharp pain, neurogenic pains, and change in bowel habits could happen. And pain could be with or without bulging. Duration is variable. Physical exam. So history will guide toward the physical examination, and examination in the obese patient is difficult and usually done in upright position, where standing and gravity makes the hernia visible. So a Valsalva maneuver is done to make the inguinal hernia prominent. The palpation could be done, and cough impulse and cough reflex should be examined. Differentiation could be made between direct and indirect inguinal hernia by putting the pressure on the internal ring, which is medial to the inferior epigastric artery. It is important if we can palpate the inferior epigastric artery pulsation. Sometimes it's difficult. The examination of femoral hernia is difficult. The hernia presents in the inguinal region, and presence of too much or little fat in the inguinal region can cause error in the diagnosis in the femoral pseudohernia. Therefore, even the presence of the smallest bulging under the inguinal ligament has to raise the suspicion of femoral hernia. Differential diagnosis include malignancy, testicular primary conditions, aneurysms, and lymphadenopathy, sebaceous cyst, hidradenitis, and neck canal cyst, varices, psoas abscess, hematoma, and ascites. So diagnosis based on history and physical examination. And we can it could also be aided by radiological investigation. CT scan is helpful in diagnosis, and an MRI can give more accuracy. And this is the herniated loop of intestine. There are different types of repairs: Bassini's, Scholdi's, Liechtenstein, and Hackenbruck's, TAP, TEP, and TIPP. And MUSH is the golden standard of the treatment because it produces less recurrence. Contraindication of laparoscopy includes the previous surgery, recurrent cases of dissection, and the treatment of hernia surgery is necessary with conservative method is not used. If there is a bad coexisting medical condition, then patient could be managed conservative, and local, regional, or general anesthesia can be used. Epidural anesthesia is also uh, used. It's a proper method. Complications could be incarceration, obstruction, which requires urgent surgery. Strangulation, when the contents, especially bowel, becomes stuck so tightly that adequate blood flow cannot reach these contents, and it requires emergent surgery. So, if there is strangulated hernia, then there is a fever, leukocytosis, hemodynamic instability, and there is tender and erythema. Recurrence, then the patient condition is important, surgical technique and tissue, and one has to use the diagnosis of recurrence. There is bulging and differential diagnosis of hernia recurrence. There could be cord lipoma, seroma, and weakness and complications of hernia surgery is pain, spermatic cord, vas deferens, cut, wound infection, seroma, and urinary retention. Sportsman hernia is occult hernia and can present with pubic pain and best diagnosed with MRI. Pediatric hernia, the prevalence of children is 0.8%. Hernia in cicatrice occurs most common after laparotomy in the midline. And types of reconstruction: mesh only, onlay, sublay, plug-in, and IPOM laparoscopic open. Hope you have enjoyed. If there's any feedback, then let us know. Thank you for your time.